Hi, everyone. We will just wait a moment and let a few more people join, and then we will get started. All right, everyone. Thank you for joining. My name is Shamira Foster. I am with the Aurora African American Health Coalition. And today we will be having a webinar presented by Jennifer Yannick on breast cancer screening, prevention, and genetics. The webinar today, we will do a question and answers at the end. So if you have any questions, just leave them in the chat box, or you can put them in the Q&A box, and we will ask them, and Jennifer will answer them at the end. You can start, Jennifer.
Okay, thank you so much for that introduction, and thank you so much for having me today. I'm really excited and honored to be able to present this information. It's something I'm very passionate about, and it's very, it's so important. So I have a lot of good information, and hopefully, hopefully you'll get a good takeaway message from this and learn something that you can put into practice for yourself. So again, we're going to talk about breast cancer, specifically screening, breast cancer prevention, and breast cancer genetics. First, we'll talk about some breast cancer basics. So breast cancer affects 1 in 8 women, so about 13%, a little over 12. In 2025, an estimated over 300,000 new cases of invasive breast cancer will be diagnosed, as well as almost 60,000 cases of non-invasive breast cancer. So invasive breast cancer gets out of the breast duct. So we have the ducts in our breasts, and non-invasive stays in there, invasive gets out. Over 40,000 women will die from breast cancer in 2025. It's way too many. The most common risk factors for breast cancer include just being female, getting a year older, and breast tissue density. And then along with genetic predisposition. So if you have like a genetic mutation, like the BRCA genes, we will talk about those in a little bit. Breast tissue density has been found to be the most prevalent of the common risk factors for women. And we will also talk further about breast tissue density and what that means for you and how you can figure out what your breast tissue density is. And women with a first degree relative, like a mother, sister, daughter with breast cancer, are nearly twice as likely to develop breast cancer themselves. So, what's the impact for African American women? The average age of an African American woman being diagnosed with breast cancer is age 60 compared to age 62 for white women. African American women are 40% more likely to die from breast cancer compared to white women. And unfortunately, they just seem to have a more aggressive type of breast cancer or get diagnosed later. And they have the lowest 5-year survival rate of any ethnic group. So that 5-year window is always a pivotal moment for women after they're diagnosed with breast cancer, because if they can make those first 5 years, it's a really good prognostic factor. And our African American women are not making that 5-year mark for some reason. 1 in 5 African American women are diagnosed with triple negative breast cancer. This is typically the most aggressive form of breast cancer. It's harder to treat, and for whatever reason, African American women are more likely to get this type of breast cancer than other ethnic groups. The BRCA2 mutation is also the most common in African American women, and the only other group that might have the same incidence of the BRCA2 mutation are those of Ashkenazi Jewish heritage, who just by nature tend to have a higher incidence of BRCA gene mutations. So do breast cancer screening guidelines overlook our African American population of women? There's large debates going on when breast cancer screening should start. all these different professional organizations have different views on when it should start. Your primary care provider's office has a different opinion. Radiologists have a different opinion. The American Cancer Society has a different opinion. So it makes it really confusing to figure out, well, which one should I follow? And so what we find the most important is that women have a cancer risk assessment done by the age of 25. So we can identify the women who should be starting sooner, who can wait until 40. Maybe even in the future, it's going to be even more personalized where we can identify maybe they can even wait until further than 40. Maybe some women can start at 50. Um, so this example below is not in practice at this time, but I think over the next several years, we're always going towards a more personalized approach to healthcare. And so um, studies are really starting to show what the differences and risk factors are among ethnic groups. And so we're hoping to gear the screening guidelines towards these findings. And again, they're not currently in use, but for example, let's say the guidelines say we should start breast cancer screenings at age 45 with an average risk person of dying from breast cancer. Then based off of different ethnic backgrounds, we can extrapolate that information to know, well, this group has a higher risk than that group. So African American women should start at 38 then. White women should start at 46, Hispanic at 49, Asian and Pacific Islanders at age 50, and American Indian and Alaska Native women can start at 51. So I think it's going to be really exciting over the next several years to see how we can tailor and more personalize breast cancer screenings in particular. So really more to come on that. And hopefully we're doing a better job taking into consideration all of these different risk factors and stay ahead of those who we can help sooner. Risk factors for breast cancer. Starting your period at an early age. So the earlier you start it, it adds a little few points to your risk score. Age 40 and older. So we talked about how just getting older, increases your risk. Alcohol consumption. So we want to make sure that we're having alcohol in moderation. We talked about the dense breast tissue, and we'll talk more in detail about that and how that plays a role and how it can be like more challenging to do a mammogram with someone with dense breast tissue. Genetic mutations play a big role. Older age at childbirth, so over like 35 and older, having menopause at a later age, family history, so any family history of breast cancer, especially at younger ages, more cases on one side of the family. So if mom's side of the family has 3 cases of breast cancer, that's concerning as well. Again, we talked about late menopause, and then hormone replacement therapy is a known risk factor for breast cancer. There's kind of an asterisk with this. If you're identified as high risk and you're really having some severe postmenopausal symptoms, hot flashes, and all those other things, there is a role and a benefit from hormone replacement therapy, even if you're high risk. But maybe at that point, you consider the extra screenings that we're going to talk about so we can monitor you better and more frequently and in different ways than someone else because of you taking this medication. Everyone deserves a good quality of life. So even though hormone replacement therapy may increase risk for breast cancer, it should still be considered for quality of life issues post-menopause. So we're going to talk about some signs and symptoms, and this is one of my favorite little visuals from Know Your Lemons. So when we think about the things we get concerned about to report to your provider, any lumps, bumps, masses, any skin thickening. So when the appearance of the skin on the breast gets thicker, maybe a little more taut and shiny, we kind of call that an orange peel appearance. Any dimpling in the skin, any nipple crusting or crusting on the areola or dry skin, Sometimes it's just dry skin, but it's worth getting looked into because there is a rarer form of breast cancer called Paget's disease, and it presents kind of with the scaling skin, peely skin on the areola. Any redness, warmth, tenderness on the skin, sometimes it's just a skin infection, but again, there is a more rare form of breast cancer called inflammatory breast cancer that can present like that. Any nipple discharge, whether it's white or clear or bloody, always report that. Any skin sores. So if you have a sore on the skin of your breast tissue and it just doesn't seem to be healing, I would definitely report that as well. We talked about bumps and lumps, growing veins, so you can kind of see veins at the surface of the skin. Inverted nipple. Some people naturally have always had an inverted nipple, and that is fine. But if you don't, and all of a sudden it flips in, you want to report that because it could be a sign of something going on in the breast. Any new shape or size, like all of a sudden, one breast is getting considerably larger than the other, or you just notice different shapes, um, always report those types of things. Everyone's breasts are different, so always become familiar with what's normal for you so you know when something isn't normal, so you can tell your doctor. This is an example of that orange peel appearance, and then any hard lump. So breast cancer screenings. We talked about how there are just lots of different guidelines out there. So what do you do? Many of these guidelines vary. When to start, when to stop, along with frequency of imaging, and it can lead to a lot of confusion. So we'll discuss the guidelines that are from the American College of Radiology, along with the American Society of Breast Surgeons and the National Comprehensive Cancer Network. These are the guidelines we follow at Rush, so they follow similar recommendations. First and foremost, a lot of breast centers are starting to utilize this personalized risk assessment. So we know who we need to target with which exam, anything additional they can do, just educating women on what their risk factors are. So doing this risk assessment gives us a lot of information about each person and how we can offer things to them that suit their own personal needs and their own risk factors. Um, so the information that goes into these risk assessments includes some of the information we talked about that increases your risk factors. So we ask, when did you get your first period? How old were you when you had your first child? We enter your breast tissue density whenever you have your mammogram, so we can figure that out, your family history and such. So all of that information goes into this risk assessment and it gives us a score. The score is not like 1 for 1. So if your score is 30%, it doesn't mean you have a 30% risk of getting breast cancer in your lifetime. It's just a number that allows us to quantify and put a number to that qualitative information, those questions that we ask. Lifetime risk will determine which supplements we offer and at what intervals. And then the patient can decide if they want to do them or not. The only thing that is gold standard and recommended for sure is an annual screening mammogram. Anything else we discuss or any of the other supplemental exams are optional. So it is up to the patient to choose to do them. We just let you know, what you qualify for and what you can consider. And then we also assess mutation risk. So when we're assessing the family history in that assessment, it will tell us if you meet the guidelines for genetic testing to make sure that there is no genetic mutation floating from person to person in your family. And we do offer that testing as well. So screening recommendations for a woman of average risk, so if their risk score is less than 20%, and they have breast tissue density category A or B, they're just going to get an annual screening mammogram, okay? If they are average risk, but they have the dense tissue being category C or D, we will recommend an annual screening mammogram, and then they can consider supplemental imaging with an automated breast ultrasound. This helps us get a better look behind the denser tissue, and we'll go more into detail about this. We call it an ABUS exam in just a minute. Women who are high risk um, or have a genetic mutation, chest wall radiation, somewhere between the age of 10 and 30, maybe for one of the lymphomas. Those are definitely things that increase your risk. And in addition to your annual mammogram, we're going to recommend you consider a screening breast MRI. That is typically recommended 6 months after the mammogram. So that way, every 6 months, you're getting some form of a breast image. At one point, you would get your mammogram, 6 months later, an MRI, and then 6 months later, it'll be time for your mammogram. So each exam would be done once a year, opposite of each other. Same, with the strong family history and the risk score over 20%. That's when we do the mammogram alternating with the MRI. Women with a prior history of breast cancer over the age of 50 and they don't have dense breast tissue, they're just going to get an annual screening mammogram. Women with a prior history of breast cancer younger than age 50 or over the age of 50 with dense tissue can consider that screening MRI opposite the mammogram. So these are the common supplemental imaging. At our facility, we do a standard 2D mammogram, but we also do digital breast tomosynthesis, which is the 3D mammogram. So I don't know if all facilities are doing that at this point, but at ours, we are doing both a 2D and a 3D. We offer that automated breast ultrasound for women who are low or intermediate risk with dense breast tissue, the breast MRI for our high risk women. All of these can increase cancer detection. None are proven to decrease mortality or morbidity at the time, okay? But there's limited studies. So the big takeaway is these all can increase cancer detection, but they cannot prevent like all-cause, death from breast cancer. So we'll start with the 3D mammogram. So you can see in this picture, the one side shows what the 2D image looks like. And it's a great picture. We can see a lot of the petals. They're starting to separate. So we get some detail there. But if you go to the other side and you see the 3D image, there are more cuts. We're starting to see more spaces in between those petals, and it's just a really more detailed image. So it really has a benefit of showing more breast cancer when it is there. So the 3D mammogram can increase cancer detection across all breast tissue densities. An average cancer detection yield is about 1.3 per 1,000 screens. And what it does as well is it helps decrease the recall rate. So if anyone's ever had a mammogram and then they're like, well, we need to get additional images. So you come back for diagnostic imaging. So the 3D mammogram use helps decrease that recall rate as well. It removes the superimposed tissue so we get a better view. And then the patients, it kind of clarifies those questionable areas that we were concerned about because we're getting more cuts and more slices and we're able to identify what that image was. The next thing is the automated breast ultrasound. This is for our low to intermediate risk women who have category C or D breast tissue density, and 40% of women have dense breast tissue. So we offer this as a supplement to the screening mammogram. It is often done on the same day as the mammogram or within 3 months of it, so we can compare tissue without any changes. The ABUS can also increase the detection of cancers, and it is not a replacement for the mammogram. So we'll get women to say something to the effect of, well, I have this dense tissue and you're saying you can't really see anything. So why don't I just do the ultrasound and not the mammogram? because nothing replaces that mammogram. The ultrasound is optional, and it does help us get a better look through the denser tissue, which we'll get a picture of in just a couple slides here. And you'll see how that tissue shows up on the mammogram, and how it can be a little more challenging. But so the ABUS does help us do that, but it's not to be a replacement for the mammogram. So what is breast tissue density and why does it matter? So breast tissue is typically made up of fat and soft tissue. The dense breast tissue has more soft tissue than fatty tissue. And having dense breast tissue just makes it a little more challenging to see through on a mammogram. And how do you know if you have dense breast tissue? So a lot of women may feel like their breasts feel dense, or they may be like, oh yeah, I have dense tissue. I can tell just by feeling. But the only way to find out is on mammogram imaging. And that will tell us what the tissue looks like on the inside. It's your genetic makeup. There's nothing you're doing right or wrong that gives you dense tissue versus not dense tissue. It's just how we're made. But there are things you can do about it to help decrease your risk. At every mammogram visit, you will get a category assigned to your breast tissue density, and it will be on your mammogram report. So I encourage all women to go to their report and find what their breast tissue density is, because it's really important that you know. So category A is mostly fatty tissue. And what this means is when we do a breast image, the image of category A tissue is mostly a black image. So mammogram is a black and white image. Category A is showing mostly black in the background, which is great because when we get concerned about something or something shows up, it shows up as white. So women with category A tissue density are getting a really great vision through their breast tissue. And if anything were to show up that we're concerned about, we're going to see it right away because that white spot on this black background is going to be very prevalent. Category B is not quite as fatty as category A. It does have a little bit of white in it, but not a lot. And so anything that shows up, we're still getting a really good picture through that tissue, and the concerning things will be found readily. Once we get into category C, that is considered dense, and this tissue shows up more patchy and white on that black and white image. So when we're looking for those white concerning areas to pop up, the concern is that those white spots are going to be obscured or blend in with those white patches, okay? And then they could possibly be missed. Category D is the most dense, so these have tons and tons of white patches there. It's probably mostly white and very little black. So we get really worried and really concerned that we're gonna miss something on these images. Now, I will say, the most concern is with the 2D mammogram because it's not as detailed. But once you get into the 3D, we are getting a better look through the denser tissue than a 2D. But it is still challenging, and people would benefit from the screening ultrasound as well. This is kind of how I was describing. This is what all of the different densities look like on imaging. So in category A, you see there's a lot of black background, so anything white is going to show up very nicely. Category B has a little bit of white patching, but mostly black. Once we get into C and D, you see these white scattered patches, and how you can imagine that if there was a little white dot behind these, are we going to see it? Where are we finding this? So it's really important that we pay close attention, do lots of slices. Really, our radiologists are really good about focusing in, making sure they're getting the best read through that 3D mammo, and then encouraging women to consider the screening ultrasound so they can get the supplemental imaging and get a better look behind those white patches. Illinois passed a law in 2019 that we need to let women know what their breast tissue density is. So again, I would encourage you to review your mammogram reports and figure out what your breast tissue density is, because by law, we need to let you know. And the reason is because of how the dense tissue can affect the imaging and finding things behind it. So um, a lot of the insurance plans that are Illinois based cover that automated breast ultrasound. A lot of states are following it. It's been really prevalent in the news recently that more and more states are adopting um, that same train of thought and covering the ultrasound to get a better look through the dense breast tissue. So we always just encourage our patients to check with your insurance to make sure it's covered since it is an optional test. The last one is the breast MRI. This is what we offer our high-risk women when they take their risk assessment. Their risk score is 20% or over. So that's kind of that cutoff. So the breast MRI is a powerful magnetic image. It has really high sensitivity in detecting cancer. And while that's great, it's also concerning because it is so sensitive, it picks up lots of other things too that may not be concerning, but because it shows up and it looks maybe a little suspicious, we might recommend a biopsy, which would end up being benign, which is great, but you end up having to have a biopsy. Doesn't happen a lot. Our biopsy rate from our breast MRI screenings is less than 3%, so it is very low. Our radiologists are very good at detecting what's concerning and what's not, and recommending biopsies when appropriate. There is no radiation with an MRI, so a lot of people are concerned about the amount of radiation exposure they get. There is very little exposure in a regular mammogram. It's acceptable, it's an acceptable amount, so I wouldn't be concerned about that. The automated breast ultrasound also does not have extra radiation. It uses ultrasound waves. And this MRI uses magnets, so no additional radiation exposure. You do require an IV to get the IV contrast dye, which is gadolinium. And it's not recommended if you are pregnant or breastfeeding because it decreases, the gadolinium can't be given while pregnant, but breastfeeding can limit the sensitivity of the MRI with the breast tissue. It's not recommended if you have a pacemaker because of the magnets. So anything metal implants and things are contraindicated for an MRI. Impaired renal function. So if you have kidney issues, the contrast dye might be a little hard on your kidneys, so it may not be appropriate for them to have. Or if you're severely claustrophobic, because the MRI, is a smaller kind of tube thing. There's an MRI image. I do have some screening recommendations for our transgender population. So our transgender females, which are male to female, if they're average risk and haven't used any hormones, then no breast imaging is recommended. If they're average risk, age 40 or older, and have had past or current hormone use equal to or greater than 5 years, then we would recommend that they get a mammogram. If they're high risk or have past or current hormone use greater than or equal to 5 years, again, we'll recommend a screening mammogram. And then our high risk who have not used hormones or have used hormones for less than 5 years, screening may or may not be appropriate. They may want to get a baseline if they're going to continue the hormone therapy for a while. And that way we know after the 5-year mark and they start getting regular mammograms if there's been any changes. Our transgender male population, so female to male, it's just going to depend on if they've decided to have any kind of surgery. And what they have is called top surgery a lot of times. And it's not the same as a mastectomy. So there's still quite a bit of breast tissue left in there. So we need to know first and foremost if they've had surgery and what type of surgery. Because patients with a reduction mammoplasty, so they've had the tissue decreased, but no chest surgery, average risk. Screening mammogram is usually appropriate. And if they have dense tissue, they can consider that ultrasound. Patients with reduction mammoplasty or no chest surgery and are high risk, screening mammogram is definitely appropriate, and again, can consider that breast MRI for high-risk screening. Now we're going to talk about breast cancer and genetics. So genetic testing is a test that looks at your genes for a genetic mutation. What that means is that a gene just isn't working quite properly, because typically our genes keep us healthy. When a gene isn't working quite properly, it makes us at an increased risk for certain diseases or illnesses. And I mean, there's all kinds of genetic testing nowadays. What I perform is cancer specific genetic testing. So I usually do a panel of about 48 genes. It covers several different cancer sites, including breast, ovarian, colon, gastric, uterine, pancreas, prostate, some melanomas, some kidney, and some endocrine genes. So it's a nice comprehensive panel. Genetic testing can be done with a blood sample or a saliva sample most of the time. Some women or men will, if they have a history of a blood cancer or have had like a bone marrow transplant or some different types of transplants, if they require genetic testing, sometimes we have to do like a skin punch biopsy. We don't do that at our facility. That has to be done like specially somewhere else, but some people do need a special sample, but for the most part, we're doing a saliva sample at our facility. I know our cancer center does a blood sample. It gives the same results. So we just don't have a lab at our imaging center, so we just do the saliva. Most of the time, genetic testing is negative. So more times than not, cancer is more sporadic or due to environmental exposures, stress, drinking and smoking, other social behaviors, or a lot of times we just don't have a great explanation why cancers happen in people. Other times we are able to identify these genetic mutations that are being passed from person to person in a family. These are a list of some concerning family history traits that would meet the criteria to consider genetic testing. Breast cancer at any age, it should be breast cancer at age 45 or younger, and they've really actually raised the age to 50. So breast cancer diagnosis in yourself or a family member, age 50 or younger, meets criteria for genetic testing. Ovarian cancer at any age in any family member. 2 primary breast cancer. So if you have 2 different breast cancer sites at the same time, or a second breast cancer at any age. So if you were diagnosed with breast cancer at age 55, and then you had a new or recurrent breast cancer at age like 65, that meets criteria for testing. Anyone, it says, 60 years or younger. I mean, really, at any point, anyone with triple negative breast cancer gets genetic testing, just because there are specialized treatments and more personalized treatments that we offer women with triple negative breast cancer and certain genetic mutations that they do benefit from. It's called a PARP inhibitor. So it's given along with your treatment from your oncologist. So everyone gets a baseline standard treatment. There's a protocol given for each different type of breast cancer. And for triple negative breast cancer with a genetic mutation, they will add this PARP inhibitor, and there's been shown to be benefit. 2 or more relatives with breast cancer. It's going to depend on the age, really. What we're looking for is 3 or more breast cancers diagnosed on the same side of the family. So whether it's like grandma, mom, and your aunt, or your dad, let's say he's got, his mom and 2 sisters. So there's 3 cases on both sides. Male breast cancer at any age, we do genetic testing for, and anyone with a history of Ashkenazi Jewish heritage with any family member at any age with a history of breast cancer, because how we talked about earlier, that's the population of people who tend to have a higher incidence of BRCA gene mutations for whatever reason. And these are the breast cancer specific genes. So most people are really familiar with the BRCA1 and BRCA2. We hear about them the most when it comes to breast cancer. But what people may not understand is there are probably at least 10 other genes, or 10 total, that also contribute to breast cancer. And so it's really important to have testing for more than just those two BRCA genes. And whenever I have patients come across my desk after their breast imaging, if they've only had the two BRCA genes, I call and I offer them update testing. And that way they can get the rest of the genes tested, because there are, many times they'll have a mutation, but it's just not in a BRCA gene. So it's important that we do the proper testing for people and make sure it's complete. So yeah, BRCA genes are one of our highest risk genes. BRCA1, BRCA2, and PALB2 are very high. If these are mutations that are found in you or your family, the recommendations for treatment are going to be a little more aggressive. They're going to be stronger to consider. You never have to do anything that you don't want to do. The decision is still ultimately yours, but we are definitely going to let you know how risky is this gene mutation. And so those high risk ones are going to give you a much higher risk up until age 80 to have that, the cancers associated with that. So BRCA cancers include breast, ovarian, pancreatic, prostate for men. So a lot of women do choose to do more aggressive surgeries when they have a BRCA mutation, just because, 80% by 80, it's a very high chance of getting another cancer in the meantime. Other genetic mutations like CHEK2, they're kind of a lower to moderate risk gene. The risk up until age 80 for one of those cancers is maybe 20 to 40%. So we talked about how the risk of breast cancer in the general population is about 13%. So 20 to 40 is still, double what the general population sees, but it's not the 80% that BRCA sees. So what do we do there? The recommendations are always there. You can do aggressive things or not, but they're just not as strongly supported. So if you don't want to do things aggressively, you really don't have to, but perhaps then you're doing that screening MRI. So you're getting extra screening. So we're monitoring your breasts more frequently than we do just someone of average risk. Breast cancer prevention. So you want to eat healthy and avoid tobacco products, alcohol in moderation, maintain a healthy body weight, exercise regularly. We talked about limiting hormone replacement therapy. Again, don't be afraid to use it if you need it, but then maybe consider some extra screening if you're high risk, so we can keep a closer eye on you. Breastfeeding is protective. Watch for any of those changes that we talked about in your breast and breast tissue, and limit your exposure to pollutants, because most cancers in general are more environmental than genetic. And then this is, one of the biggest things is know your risk. We talked about having this risk assessment done by age 25. So we know, are you able to start high risk screening at age 25? Because we do start as low as 25, 25 to 30. Or are you average risk or low risk? And sure, wait until 40 and you'll be fine. Just report any changes in your tissue. This website here is a link to the most common model that we use. It's called Tyrer-Cuzick, and it will ask you a few questions, and it will tell you what your score is, and it will be in a percentage. 20% or higher is considered high risk and can consider the high risk screenings with the breast MRI. The only thing you may or may not know when you're filling out that is your breast tissue density. That does play a role into your risk score here. So if you don't know it, you may want to redo your risk score once you go back to your mammogram report, or find your report before you do this questionnaire. So you can plug it in so it'll be more accurate, because denser tissue will, add a little bit of risk to your score. And that is all I have today. Happy to take any questions.
Thank you so much, Jennifer. We do have a few questions. So some of the questions you may have answered, and if you did, can you just answer them again? Just give us a
Absolutely.
refresher. So the first question is, how do socioeconomic factors and healthcare access influence screening rates?
Yeah, I mean, it plays a huge role because, people who are struggling financially or socioeconomically aren't always the people that are good about seeking healthcare and regular healthcare maintenance. Um, I would like to encourage people to spread the word that screening mammography is free, right? So if you have any insurance, screening mammography is free. There's um, always a good reason to do it. So there is no cost there. You just have to get in to do it. Now, I mean, I get the concern, well, what if something's found and then we have to go from there? So that kind of adds another layer that would have to be dealt with at that time, but at least you're dealing with it. Um, the Illinois Breast and Cervical Cancer Program does have a program that will allow you to get screening mammograms, as well as if you're having breast issues and you don't have insurance. It's usually through like the VNA, or if you go to your provider, they should have resources on how to access this, but they'll give you a voucher. So you can have whatever breast issue you have worked up. And then what usually happens if that turns into something, then the Illinois Breast and Cancer Cervical Cancer Program, then you apply for a medical card. Most people end up taking that route and qualifying. Some people don't, but lots of hospitals have charity care that they then apply for. Um, but for the most part, people do work well into the Illinois Breast and Cervical Cancer Program, which is kind of a more specialized program with Medicaid. And then all of those services are covered, including that diagnostic imaging if you've got an issue, as well as, let's say it needs a biopsy, they'll cover the biopsy. If the biopsy is cancer, it'll transition into your cancer care.
Okay, thank you. The next question is, how can providers ensure culturally competent communication around risk density and genetic options?
Yeah, it's a great question. So it's really about them being knowledgeable about what breast tissue density means, what a risk score means. That's part of my job is I reach out to people in our facility who meet certain requirements, send them a message or call them. So they're aware of those things and what options are available. But all providers should be aware of those risk factors so they can be addressed and discussed. And then one of the best things a provider can do is do a very thorough family history. Excuse me. Because if we're seeing someone in the office and let's say they're like 22 years old, 23 years old, you get that family history and mom had breast cancer at age 45. Well, we need to see this person, right? We need to plug them into the system now. So um, we know how high risk they are and offer them the different things that they would benefit from. So one of the main things is at a young age is getting one of these risk assessments, or at the very least, a very thorough family history. So we can identify the people who need these services the most and get them plugged in sooner than later.
Thank you. The next question is, how can we advocate for improved education and access in our communities?
Um, yeah, I mean, maybe just discuss with the organizations and provide more education like this seminar. Um, you know, talk to your providers when you're there about your concerns about breast health and breast issues. Are we doing enough? How can we educate more? Um, Look in your community for other programs and other seminars being put on, and just kind of knowing those resources like that website I gave you, so you can get your own risk score. When you get that risk score, you can go to your provider with that information and be like, hey, I took this risk assessment. I'm high risk. Um, I can start a screening mammogram now. Um, things like that. I mean, there are some caveats to it. Like I think some insurances don't allow a screening mammogram before the age of 30, but you can still do the MRI from 25 to 30 and then start adding the mammogram in starting at 30 and alternate with the MRI. So I would say asking questions and seeking out more education opportunities and sharing that with your providers to provide them more information. And hopefully they're also seeking it out because it's really, it's such an important topic. And um, I think all around, we're starting to see a lot more cancers at a younger age. I know breast has been that way for a little bit, but colon is really starting to have that happen. So, just, always being in communication with our provider about things that may or may not be going right or wrong, and having them work that up in a timely fashion and not putting them off like, oh, it's nothing. Just give yourself some peace of mind and go ahead, have it worked up, and that way everything's good. And when you're plugged into screenings and things like that, then you're in the system. And I know, like at our facility, you're going to be in there, and we're going to keep a contact with you, let you know what you qualify for, and hopefully, you're able to do some of the extra things if you're meeting the criteria for it because you will benefit.
Okay, thank you. And I did drop that website in the chat, so if anybody wants it, it is in the chat.
You're muted.
Okay, sorry.
Okay.
What emerging research or technology might improve early detection in high-risk individuals?
Yeah, so definitely the 3D mammogram is definitely helpful. Um, the use of the MRI as a screening tool is very helpful. There is also another exam that I didn't touch upon. It's called a contrast enhanced mammogram. We don't offer it at our facility, so I don't have a ton of information on it, but some other facilities have it, and it would be a really good option for women who want that contrasted image like an MRI, but can't have an MRI for some reason, like they have metal in their body or a pacemaker. So they do offer a contrast enhanced mammogram. So I do think we're going to start to see that more coming in the future.
All right, thank you. And we are on Facebook Live right now. We did get one question on Facebook. And the question is, what are the barriers to accessing genetic testing and advanced screening for underserved populations?
I just think some of it is knowledge, just not knowing that it's available to them. I also use both of the genetic testing companies that I use for testing have financial assistance plans. So even if you don't have insurance or have insurance, but it's not that great and maybe won't cover your testing, um, they have financial assistance programs that, based off of number of people in the household and financial information, you don't even have to submit tax documents. You can always just say that no tax documents available and they don't ask for them. But there's all kinds of resources out there to tap into it and still have these done. The other thing would be talk to your families. We've got Easter coming up. You're going to be with family, maybe. Take these times to really talk about family history. One of the issues is that there's whole generations of people that didn't talk about health, right? So, like my grandparents and, their generation, they're like, we're not going to bother people. We're just going to deal with this ourselves and keep it private. And so that works for them, but what about us? Like now they had this thing that maybe allows me to get better care and additional care. And I didn't know about it because we didn't talk about it. So encourage your family to talk about it and let them know how it impacts you so you can know the information, if they've had any cancer and at what ages, because that's how we're going to know people who qualify for genetic testing based on guidelines. Now, I say based on guidelines because it is more likely that insurance will cover it when you meet those guidelines. However, anyone can have genetic testing at any time. the companies that I test with, one of them, both of them kind of, really the maximum out-of-pocket cost for that is about $250. And not that that's inexpensive, but if you could save it up because you're really interested, and you don't want to wait until you have enough cancers in your family, to qualify for testing, anyone can have it done. You just may have to pay out of pocket for it, but most insurance companies will cover it if you meet the NCCN guidelines that we follow.
Okay, thank you. And we have one more question before we wrap it up. Can you discuss the role of systemic racism on treatment and screening?
Um, that, it's a tough topic. I would like to think that we don't discriminate for our screenings because they're there for a purpose and um, we want everyone to get the best care they can. And so when they come into our facility, we try and treat everyone with respect and dignity and make sure everyone gets the care they deserve. In terms of, racism, like maybe if you're reporting an issue to your doctor or something, I can't pretend that it's not an issue. There are definitely problems that we have seen in the past. I would encourage just, strong self-advocacy when you know something's wrong and you feel it in your gut and you know your body and something's not right. Always just advocate for yourself. And if someone's not doing what you want them to do or ask them to do, don't hesitate to go seek care somewhere else. There's no one saying that you can't go get a different doctor or get a second opinion or whatever. And I would strongly encourage that. I even encourage that to my new diagnosis breast cancer patients, just so they have better peace of mind, and they find the fit for them. Because you need to be comfortable expressing yourself to people and knowing that they're hearing you. And that's part of the problem with when racism kind of comes into play in healthcare. Definitely find your person, and have your voice heard, and don't hesitate to make that change when it's not.
Okay, well, thank you so much, Jennifer, for a great presentation. We will hopefully be able to meet with you again and do another presentation sometime in the future. And thank you everyone for joining. And I hope you all learned something. I know I did.
Good, I'm glad. I hope everyone learned something.
I'm sure we all learned something. Thank you.
You're welcome. Thank you for having me. I appreciate it.
You're welcome.